Hello everyone. So in last class we had discussed regarding the anatomy of nose. So today in this class we will be discussing regarding the diseases of nose. So first let us start with a condition that is none other than choanal atresia. Atresia is none other than development, problem in the development. So here what happens, this choanal atresia is because of the persistence of primitive bucco-nasal membrane. So in birth, in newborn babies, we may get this condition and it can be identified through its symptoms that we will be discussing further. So here in case of choanal atresia, it is because of the persistence of primitive bucco-nasal membrane. Bucco-nasal membrane. Okay. So here the main symptoms were airway obstruction, and cyclical cyanosis. Cyanosis is bluish discoloration because of the lack of oxygen and increased amount of carboxyhemoglobin. So here it is cyclical cyanosis, and this we can see mainly in the bilateral atresia, which is life threatening in case of babies. Okay, so these were the symptoms. So how we can diagnose? How to diagnose the condition? So there will be presence of mucosal discharge in nose, mucoid discharge. Then comes absence of air bubbles in nasal discharge. So that is, it is indicating the lack of air. So in case of nasal discharge, there will not be any air bubbles, and inability to pass the ET tube. NG tube. Nasogastric tube. So these were the points where we can diagnose the choanal atresia. So I am repeating, choanal atresia. It is because of the persistence of primitive bucco-nasal membrane. And here how we can identify, because of the airway obstruction and cyclical cyanosis. If mostly it is seen in bilateral and it is of life-threatening condition. Then comes the diagnosis. Presence of mucoid discharge, absence of air bubbles in the nasal discharge, and inability to pass the NG tube, that is nasogastric tube. This is how we can diagnose this condition. So let us move on to the next topic. So next topic is acute sinusitis, the frequently encountering condition in our OPD setup. Acute sinusitis and chronic sinusitis we can easily notice. So the common etiology is streptococcus pneumoniae, and then comes the order of affection of sinuses. So there comes a pneumonic. So first comes the maxillary sinus, more than FR is for frontal, more than ethmoid, more than sphenoid. Okay. So this is how the sinuses get involved with infection. Max price. So max for maxillary sinus, FR for frontal sinus, E for ethmoid, and S for sphenoid. Okay. So now let us see the signs and symptoms associated with each different types of sinusitis. One is maxillary sinusitis. So now let's see how the presentation is. There will be maxillary tenderness. That is, if you press behind the nose, you will have the tenderness there. Okay. So here all other symptoms are normal, but in case of common symptoms will be there like postnasal dripping or a headache, everything will be there. But here you will find maxillary tenderness. So whenever a patient of sinusitis is coming, we should examine the face by pressing over it to find which sinus is getting affected. Then comes frontal sinusitis. Here, the major thing you have to remember is office headache. So what happens? While going in morning, the headache rises, and by afternoon, it increases more like this. Morning, it rises. By afternoon, it touches the peak, and slowly it gets down. Okay, by evening. So this is how the pattern of headache we can see in case of frontal sinusitis. Okay. Now regarding ethmoid sinusitis. So in case of ethmoid sinusitis, two things have to remember. Most common in young children. Mainly children, you remember. And then orbital, in case of orbital cellulitis, the most common condition leading to orbital cellulitis is ethmoidal sinusitis. Okay. Then comes at last sphenoid sinusitis. So how the presentation will be there. So in case of sphenoid sinusitis, there will be severe retroorbital headache and PND, postnasal dripping. So these are all the things associated with manifestations associated with sinusitis. First, let us start with this. Most common Streptococcus pneumoniae, and this is how the infection occurs in case of sinusitis. That is max price. Max for maxillary, FR for frontal, E for ethmoid, and S for sphenoid. Then in case of maxillary sinusitis, there will be maxillary tenderness, and in case of frontal sinusitis, there will be office headache. The rise will be starting from the morning and peak will be there in afternoon, and there will be decrease by evening. Then ethmoid sinusitis, most common in young children, and in case of orbital cellulitis, it is mainly due to ethmoidal sinusitis. Then comes the sphenoid sinusitis. Here we will find two symptoms in prominence. One is retroorbital headache and then PND. So now we have to discuss regarding the imaging techniques of sinusitis, how we are going to identify. Okay. Imaging. 1 minute. I will continue with the class. So, as told before, we are going to discuss regarding the imaging techniques. So first, we will talk mainly regarding X-ray because this is more important than any other investigation. So in case of X-ray, we have different views which is more important. So first comes Waters' view, which is also called as submento occipital view. And here we can see all the sinuses except posterior ethmoids. Then comes Caldwell view, and here we can easily view frontal sinus. Then comes basal view, where we can view mainly posterior ethmoid and sphenoid. So in case of imaging X-ray, first is Waters view, Caldwell view and basal view. Waters view, submento occipital, we can see all the sinuses except posterior ethmoid. In case of Caldwell, it is frontal sinus, and in case of basal view, we can see posterior ethmoid and sphenoid. And here we may expect a complication, which is an interesting terminology. Parts puffy tumor. So what it is, parts puffy tumor, you may think that it is a tumor and few people might be knowing also. So here it is not exactly tumor. It is none other than osteomyelitis of frontal bone. So this is simply osteomyelitis of frontal bone. So I think you know this, that if the name is not indicating the explanation of the disease, it is commonly called as misnomer in medical science. So this parts puffy tumor is one of the misnomer which we are studying now. So in case of sinusitis, this parts puffy tumor might be a complication. Next let's start with atrophic dermatitis. Atrophic is none other than shrinkage. So atrophic rhinitis. So here let's start with the causation. So causation you can hear in a very short form, that is hernia. It may be of hereditary origin, or it may have any endocrine causes such as starts at puberty and stops after menopause. Then any type of racial integration you can expect. And then comes N, that is nutritional deficiencies also lead to atrophic rhinitis. Nutritional deficiencies. And then comes I, that is infections. And then that is A is none other than autoimmune. So these are all the primary causes of atrophic rhinitis, which can be called as hernia very easily. Then regarding the pathology, so here why it is happening, that was the question. So basically the linings were of columnar epithelium. Okay, in case of columnar epithelium, we will be having glands and secretions. Everyone knows that. But because of this etiology, this columnar epithelium gets converted into stratified squamous epithelium. Okay. So what happens in case of stratified squamous epithelium? There will be no glands for secretion because all the glands are associated with columnar epithelium. So here there will be no glands. So finally, no glands is none other than atrophic mucous glands, and adding to that, because of the end arthritis, obliteration of end arthritis, it will lead to the resorption of turbinates also. Okay, so this is how the pathology of atrophic rhinitis occurs. Just remember that all the columnar are getting transferred into stratified squamous, leading to this atrophicity. So how we are going to diagnose it clinically? Clinical features. So first, here there will be merciful anosmia. So anosmia is inability to smell anything. Here the merciful thing is patient cannot smell anything, but the people nearby to the patient can smell a bad odor. So that's why even the patient is not having the smell. So it is called as merciful anosmia, and there will be roomy nasal cavities. Nasal cavities would be very broad. And then Ozena is none other than because of severe atrophic rhinitis, there will be extensive crusting and fetor smell. That fetor smell is leading to the merciful condition to other people around the patients. So this is all regarding atrophic rhinitis. Okay. So this you might have seen in our Materia Medicas 2, Ozena, which belongs to atrophic rhinitis. So let's move forward. So here, now let's start with rhinosporidiosis. Rhinosporidiosis. So let's see what it is. It is caused by the fungus Rhinosporidium seaberry. Okay, Rhinosporidium seaberry, and it is common among farmers, and this is most common in South India, Sri Lanka and Pakistan. Living North India, the disease directly gone to Pakistan. So now these are all the most common areas getting affected, and here there will be bleeding polyps. On examination, what we will get? We will get bleeding polyps which resembles strawberry, which appears like strawberry. Why it is appearing like strawberry? It's because of the spores. These white dots on the bleeding polyp is indicating the sporangia, that is spores of the fungus. Okay, so this is rhinosporidiasis, which is caused by the fungus Rhinosporidium seaberry, and it is most common in South India, Sri Lanka. Leaving North India, it went to Pakistan, and bleeding polyps will be there. It looks like a strawberry, and it is this white dots are indicating the sporangia. Okay. So now next condition, rhinoscleroma. So with the name it is indicating that there is some type of sclerosis happening. So let's see what it is. This rhinoscleroma is also called as woody nose. Okay, and here it is caused by Klebsiella rhinoscleromatis. Rhinoscleromatis, which is also called as Frisch bacillus, and it is of gram negative. And here something interesting, that this rhinoscleroma is more in North India. So now the gap is fixed. North India, we can check for rhinoscleroma condition. Okay. So here you have to remember two important pathological bodies. One is Mikulic cells and Russell bodies. Russell bodies you can see in case of multiple myeloma also. So try to remember. So in case of rhinoscleroma, you have to remember this Mikulic's bodies and Russell bodies. Sorry, Mikulic cells and Russell bodies. So now moving forward. Regarding nasal polyps. So there are two basic differences. One is antrochoanal polyp and another one is ethmoidal. So here the basic thing you should know is few points, 2 points in each. One, it is due to infections, and here this ethmoid is due to allergy. Ethmoidal is due to allergy, or it may be associated with asthma. Okay. It mainly arises from maxillary sinus. But this ethmoid, name itself indicating it arises from ethmoidal sinus. Okay. So this is all regarding the nasal polyp. So moving forward. So for this video, this will be the last condition which we will be discussing. CS of rhinorrhea. So in this condition, few tests you should know. So first let us start with the most common condition leading to the CS of rhinorrhea. The most common cause is accidental head injury is leading to the condition. Accidental head injury. And here what happens in case of accidental head injury? There will be traumatic fracture in the lateral lamella of cribriform plate. Okay. So here what happens? There will be most common accidental head injury will be there and fracture will be on the lateral lamella of cribriform plate, and two signs you should know. Sorry, two tests. First, how we can identify this? There will be history of leakage of clear fluid which cannot be sniffed back. If it is nasal discharge, you can sniff it back, but here you cannot sniff it back. Okay. So here there are two different tests to identify. Handkerchief test. So we always have difficulty whether the water coming from our nose is coryza or CS of rhinorrhea. So in case of mucus or coryza, the handkerchief gets stiff. Stiff it is. Stiffening will be there. But if it is CSF, no stiffening will be seen. Okay. And then comes double ring or target sign, target or halo sign. So here what happens? There in case of traumatic CSF leak, if we collect the paper in the filter paper or handkerchief, blood will be staying in the center and CSF will be gravitating towards the periphery. So this is how you can identify, and it looks like this, leading to the double ring, target or halo sign. So this is regarding CS of rhinorrhea, and there is a best confirmatory test to identify the traumatic CSF rhinorrhea, that is on electrophoresis and electrophoresis beta 2 transferrin is specific for CSF, and this is the best confirmatory test you can get in CSF rhinorrhea. So in next class we will continue with the topics. Thank you so much and happy learning.